Let's get back to our interesting parts here, people, and I apologize again. So here we go. This is a chest wall mass in a 74-year-old patient. It's all soft tissue, and these are fragments from part of that excision or resection of the chest wall mass. I don't have a size, but it is all soft tissue, and there's no bony involvement. From here, you can see that it's fairly cellular. Okay, the morphology is not very good here, but clearly malignant. And let me find a better, thinner section that I can share the morphology with you. This might be better. Okay, these are areas of necrosis, so geographic necrosis. Again, an elongated vessel with tumor surviving around it, and these pink areas are necrotic. And I generally share those data with you, morphology with you, because it's difficult. Most of you are overseas, difficult to probably get good vision and pictures. So here's the tumor. There's a vessel on the top corner of this field, and here you can see these large tumor cells, large nuclei, prominent nucleoli. Cytoplasm is not quite pink and not quite blue, so it's what I like to call amphophilic, somewhere sort of in between. But this is pretty much the tumor itself. Wherever we go, let's go to different areas here. You can see this abundant cytoplasm, many of these cells with large prominent nucleoli. Okay, and this is probably the highest we can. Yeah, there we at almost 50, 60x there with this field. So any thoughts of anybody? Chest wall mass, soft tissue, 74-year-old, no bone involvement, and it was pretty large. I just don't have a size for you. Any thoughts? Give me your differential diagnosis, and we can discuss them. Epithelioid sarcoma. Okay, Irene, that's a good start. So for epithelioid sarcoma, we'd like to do the CD34, the keratin, and the EMA to start off with. And Sheena's mentioned lymphoma. I think you have to rule out a lymphoma, diffuse large lymphoma, as well as an anaplastic large cell lymphoma. Those would be appropriate. CD30 ALK being useful in that context. Yes, Maria Jose, lymphoma as well. Yan, epithelioid angiosarcoma. I'm glad so the lymphoma markers are negative. Let's get that out of the way. And so are the histiocytic markers, Solomon. They were negative as well. But these are good thoughts. You're thinking of large cell malignant neoplasms. Of course, Sheena, melanoma, it's the one I showed you last month or the month before in Thai. Always be careful of melanoma, so you need to rule that out. I typically do S100 and SOX10 as screening tools, but if you know there's a history of melanoma, you would then have to resort to your mainline melanocytic markers, and you know those, melanA, HMB45, tyrosinase, and PRAME. MITF also falls into that, and you sometimes have to resort to BRAF V600E. And remember that you can also have the so-called trans-differentiated melanomas where the markers are negative, and you may resort to molecular analysis in order to confirm that and or a history of melanoma. So the melanoma is an important component of that. Isabel has mentioned germ cell. I like germ cell tumor. This was a lateral soft tissue tumor. If it was mediastinum, and I did not say that, but mediastinum would certainly entertain germ cell tumor, the large nuclei, sort of reminiscent of an embryonal carcinoma, if you will. Generally younger patients, but older patients can have mixed germ cell tumors in the mediastinum as well. But those were negative. The germ cell markers are negative. Again, for that, I typically do the cell4, and I may use OCT3/4 as well in conjunction with that. But if I'm thinking yolk sac like areas, then I would do the glypican and the other markers for yolk sac tumor. alpha fetoprotein as well. Let's see. We are working very hard. Yeah, I like dedifferentiated liposarcoma. MDM2 is an easy way to rule that out. Um, Pleomorphic liposarcoma are these vacuolated cells. Um, they are vacuolated. The question is, are they lipoblasts? That's the question. Let's just pause there and look at some of these cells. And you can see they vacuolated. I think they are artifactually vacuolated. And remember the lipoblast where the vacuole has to indent the nucleus. Um, you may argue some of these are indenting the nucleus, uh, but typically they would cause this sort of major indentation into nuclei, and that's a useful feature. Uh, let's see, more vacuoles. Yeah. I think some of these are mainly artifactual. And then that's the reason I like your differential, because I did not even think of a pleomorphic liposarcoma in this context. Now, Gopal's coming there. We had the first Irene suggest epithelioid sarcoma. What I did not say to you then was that INI1 has to be done for the epithelioid sarcoma, which is intact. And that's the SMARC-B1, looking at the SMARC proteins. But here we have a suggestion of a SMARC B4A1. I think it's A4B1. Is that a bit of a translational mutation? Just help us there. I'm getting confused as well. But this, in fact, is a SMARC A4 loss. So the BRG was lost. Keratin was positive, and so this was signed out as a SMARC A4 deficient tumor or neoplasm. And when you go back in the literature about the SMARC deficient neoplasms, one of the earliest ones to have been described was the so-called thoracopulmonary SMARC deficient neoplasms. And this fit in very well. There was no other tumor elsewhere. This was on the chest wall. And it's the SMARC, I'm getting that confused. It's SMARC, yeah, it's a SMARC A4 and B1. So this is SMARC A4, which is BRG loss. And that's what we call this high grade. And if you looked carefully, you may see some sort of rhabdoid cytoplasm, but they're few and far in between. Useful are the large nuclei, some of them looking eccentric, but not as obvious as the typical rhabdoid cells that we see, for example, in epithelioid sarcoma or in rhabdoid tumors of the kidney. So epithelioid sarcoma was in the right track, Irene. This did have some patchy cytokeratin as well. But ultimately, thinking of the SMARC deficient neoplasms is the helpful feature. Squamous carcinoma, you'd want the NUT P63 to be positive, as well as NUT P40 P63 for squamous carcinoma, and then of course NUT being positive. That's a good thought. And the original NUT description, NUT carcinomas, was midline, but now we recognize that they can occur outside of the midline, not necessarily confined to the head and neck, and they've been described in other sites as well. I think, yes, you could do the NUT here as well, even though the morphology does not fit the classic description of NUT. There was a paper in Histopathology about a year ago showing the spectrum, the broader spectrum of NUT carcinomas, which can extend to clear cells and squamoid areas and even adenocarcinomas. So if you're thinking NUT, just do the antibody. That's what my method of making a diagnosis NUT carcinoma. In the early days, it was always basaloid with abrupt squamous differentiation in younger patients. But I think when you're desperate and don't have a definite histochemical profile, then think NUT, think SMARC, think of things that are outside the usual carcinoma morphological profiles. So all good differentials and good discussion. Oh, there is one here that I missed, Mosaic-Kumo, clear cell sarcoma of soft tissue. They tend not to be so wild looking. The nuclei, they do have prominent nucleoli, but they're much more uniform. They're much more nested, and also younger patients, and more often in the extremities, clear cell sarcoma in the extremities. And of course, you would have S100 SOX10 to help you there to start or launch into that category, and then the melanocytic markers, and then of course the final diagnosis being confirmed with the fusion, which includes the FET-CREB family, okay, FET-CREB family of tumors, which I'm not going to go into, but there's a whole host of them there. So it's another fascinating area. Epithelioid sarcoma, yeah, and yes, I think the wild-looking high-grade ones and ERG would be helpful in this regard. Just remember that CD31 cross-reacts with the histiocytes, so that histiocytic sarcoma, Solomon, think of angio as well, because those can be membrane positive in histiocytes. Okay, let me see. Are there any other questions? Squamous met. Okay, let's move on to the next one that I have here for you. Much lighter one. I see 26246. 26246. Okay, how about this? This is a finger mass in a young adult, and that's pretty much it. I don't have a ruler on this to give you a size, but anyway, probably is. I just don't know how to operate it. But here you can see this very well circumscribed neoplasm submitted as a finger mass. And let's see what you think of this. Okay, well circumscribed, like I said, a little bit of myxoid matrix, and then going down to the tumor itself, some cells which are ovoid, uniform and very ovoid looking. These vessels here, okay, with the same. Okay, I'm getting some differentials coming up on the chat, and I appreciate that. Myxoid matrix, and look here, you even have some spindle cells. Okay, so I've got glomus tumor. Typically, the glomus tumor, as you know, are very nested with these round ovoid cells arranged around vessels. Typically, some of these areas do look lomoid. There you go. These do look lomoid. And then there are other areas that look spindled, like these areas here. And then you may argue, well, could this be a glomangiomyoma? Because you can get spindle cell differentiation as well. What else do we have? We have myopericytoma. Good spot, Isabella. I see these concentric arrangement of the cells are very typical for myopericytoma. Glomus tumor, myopericytoma, glomus versus myopericytoma. I like that TBA, glomus versus, because I couldn't really make up my mind what this was. Here you can see these staghorn vasculature, which forms part of these tumors. Here, more spindling of the cells and more ovoid. You could say it's a diffuse glomangiomyoma. You could call it a glomus tumor, that would be fine. And then if you thought that these vessels were prominent, you could use the word myopericytoma as well. So my point being that this belongs to the perivascular myeloid tumor group, and all of those tumors that we've talked about, the glomus tumor, the glomangiomyoma, the myopericytoma, the glomangiopericytoma, and the myofibroma, which we've not talked about. Myofibroma, I remember, also has these ovoid to spindle cells, but there's a zoning phenomenon, and the zoning phenomenon separating the cellular areas from the myeloid areas, along with this staghorn vasculature that you see here as well. So all of them belong to that category, and the reason I put this in was I couldn't really make up my mind, just based on your differentials here as well, whether this was a glomus tumor or even a myopericytoma. Now, myopericytomas are typically dominated by these. You can see a vessel here with this concentric arrangement of the cells around these vessels. That's very typical for a myopericytoma. The other one is an angiomyoma, and there you would have the smooth muscle cells peeling off these vessels, somewhat reminiscent of this one. And this I found just to be, a sort of seminal example of a perivascular myeloid tumors with glomoid areas, nested cells around vessels, myeloid areas, and angiomyoma areas, and then even myopericytoma-like areas. So in the end, I just called it a benign perivascular myeloid tumor because I really did not make up my mind, and that is shown by your differential diagnosis in the chat as well. So I think understanding all of these, 5, 6 different tumors that belong to this group and knowing their morphologies is helpful. The glomeangiopericystoma, remember, is confined to the sinonasal tract. I don't make that diagnosis in soft tissue, but all of the others I've seen, particularly in the extremities. Remember, glomus tumor can occur in other sites as well, like in stomach, GI tract. They can occur in bone, so keep that in mind as well. I've even seen one in the branching of the bronchi, glomus tumor there as well. Okay, any other questions or comments on this? Okay, so far so good. Let's move on then. The next is 24708. 247 right there. And this is sinonasal young adult with a septal perforation. So this is a typical slide that we see in our sinonasal curettings. I call them just curettings, but just to take you through the sinonasal mucosa here, that's an artifactual folding, respiratory type epithelium, basement membrane, and then the seromucinous glands, and then these thick wall vessels as well. Okay, so that's the typical bone, trabecular bone that you're familiar with. But the reason I'm showing this to you is because of these areas here. And I just want to go in here. That's bony trabecular here at the base. That's sinonasal surface mucosa there. All right. Maybe a little metaplastic, severe chronic inflammation. And then here, I'm going to place this, the center of the field. This almost geographic area of necrosis, sort of linear geographic necrosis. And then look at what's bordering that here. Okay, I will tell you that many of these are histiocytes. Okay, because I did confirm that with the histiocyte marker. I typically do the CD163, which I find to give me a clear background, a much cleaner background, sorry. So here we have histiocytes almost palisading around this geographic necrosis. And then I think there was one on this side as well. If I can find that for you. Again, severe inflammation, just to show you the high power view of this inflammation. A lot of plasma cells, a lot of lymphocytes, all mature, nothing concerning for lymphoma. And here's the necrosis, which is fallen off here, but again has that geographic arrangement and this palisading histiocytes around that area. Okay, there's a large vessel there, another vessel here, just to point out the vessels. So let's see, what's your slide not moving? Oh dear. Okafor, is it moving now? Because I've been moving it all along. Anybody else having that problem? It's moving. Sajani says it. Murani says it's moving. Okay. What are your thoughts? What do you think of this? So in summary, what I've been is the vascular. Well, Maria Jose, I did show you the vessels in that area here. There we go. Nice, clean-looking vessels. Okay, clean vessels. So, in summary, no vascular inflammation that I saw, Maria. Good thought. What was you thinking of? What was your differential in that respect? Anybody? Any fungal elements? No, Irene. We here in this laboratory like to do Grocott stains for fungal elements, and those were negative. I did the Grocott stains. I have to rule out fungal infection. because of invasive fungal sinusitis, which is a critical value, isn't it? You have to phone your surgeon and tell them, even it's a Friday night, that you have invasive fungi. So, yep, you have to do the fungal infection. TIBA, same that we're talking about. So, not vasculitis, Maria. And what you're thinking about is GPA, granulomatous polyangiitis, okay, previously known as Wegener's granulomatosis. You do have the necrotizing granulomatosis. The geographic appearance of it would support that, appearing necrosis as well as the granulomatous inflammation. But there's no vasculopathy, so no vasculitis. Aha, Jan, that's a great question. Did he use cocaine? And that was in my differential. Fungal infection was in my differential. Cocaine was in my differential as well. Again, there's no vasculopathy that I could see, but that did enter my differential diagnosis. Remember, cocaine causes a stricture of the vasculature, and they become thick-walled with reduction in the lumen. These look pretty okay. But there's a way of checking for cocaine as well. Is you can use a polarizing microscopy, and you can see these polarizable foreign elements in the inflammation. This did not have any. I did not see or find anything. So cocaine enters that. R says, I don't know if that's Rouhani. R says rhinoscleroma, and that's referring to rhinoscleromatous granulomatous. Is that the Klebsiella one you're thinking about? Klebsiella rhinoscleromatous. And those typically have a lot of plasma cells, histiocytes. Within the cytoplasm, it's an intercytoplasmic organism. You see these Klebsiella organisms, and they have to have a safety pin appearance. And you can use a GIMSA to show that. I actually did the GIMSA here as well, but that was negative. Typically, you see a lot of plasma cells, and you see a lot of these eosinophilic bodies for that. So, although I didn't think it was that, I did do the GIMSA looking for the Klebsiella organism. Maria was, Wharton study. Always, you have to think about syphilis in this context, because remember, syphilis can affect the sinonasal tract as well, and that was negative. Yes, we did the Wharton study. In fact, the Wharton study, which is a silver stain, encoats the organisms, and it's a very difficult, finicky stain, a very difficult one to execute. We have an antibody to spirochetes, so very fortunate to have that, and it's useful, very useful. It picks out the nice spirochetes with their typical morphology. So it was screw type morphology. That was negative, Maria. So that's a good thought. I'm glad you thought of syphilis. It's on the uprise when you look at the sort of popular press as well talks about it. It's on the uprise, and so even so is HIV actually. So be careful of that, and think about the old, different stages of syphilis. And if you see something with a lot of plasma cells and even vasculitis, and sometimes even granulomas, just throw Wharton study or a Treponema spirochete to demonstrate those spiral organisms. NK cell lymphoma, pretty. So earlier when I went down on high power, I said it was mature, and I did that deliberately because NK T cells typically have very irregular membranes. And remember, those are also angiocentric with angionecrosis, so that has to be a consideration as well. And quite easily come in quite easily diagnosed with thank you, Tiara. Quite easily diagnosed with the CD56, CD3, which is positive in NKT cells, but EBV, in situ hybridization for EBA is useful, and we have that in our laboratory. So that was negative here. Pretty, I did that earlier on, so that was negative as well. Sajni, IgG4 with all these plasma cells, you have to consider that. And IgG4 would come into that differential diagnosis. remember the IgG4 lymphoplasmacytic sclerosing disease is a morphological description, okay? Morphological description. Can you get necrosis in that? I believe you can, but it's exceptionally rare, to my knowledge. And, I've seen a handful of IgG4s, but none of them have had necrosis. But I remember looking it up in the literature, and you can do that now to check that out as well. But I've never seen necrosis myself. But again, easily ruled out by doing an IgG4 in comparison to a CD138, because you're looking at the ratios. Is the IgG4 increased? And that's probably the best way. Now remember, it comes with the triad, right? So you want fibrosis, storiform fibrosis, and you want a obliterative phlebitis. Now remember, I showed you the vessels. The vessels are pristine here, okay? They're clean, and they don't have any of that obliterative phlebitis. So any history of radiation or other chemotherapy? No, not that I'm aware of. Is a young adult with septal perforation. So in the end, it may just be cocaine, and I never put that in my report. So I described it as being necrotizing granulomatous inflammation. I asked for serology to be done, meaning the anchor and all of the other antibodies, to rule out the vasculitides, and then that pretty much was it. But I suspect it was probably cocaine with perforation, and that the anchor antibodies were negative. So remember that just having a high IgG4 in its own right does not make a diagnosis of IgG4 lymphoplasmacytic sclerosing disease. You want the triad. You want all three before you suggest the diagnosis. And then again, this clinician has to corroborate that with a mass-forming lesion along with a raised serum IgG4, even though some recent literature talking about normal IgG4s. But in any event, you want a mass, and you want IgG4 to be increased in the serum along with your morphological changes, and you've got to have the triad in order to make that diagnosis. Remember, patients with that diagnosis are going to go on to steroids, long-term steroids to manage and treat that. Kappa and lambda, I don't think I went that far, but good thought. It's a good thought. I mean, this looked mixed to me, Maria, with lymphoplasmacytic with this necrosis, and he has he just has this history of septal perforation with necrotizing granulomatous inflammation, and I think all of those inflammatory autoimmune diseases we talked about would probably come into that differential. But you guys thinking really nice and outside the box. Radiation, I like. IgG4. All of these are very relevant. So good discussion and good differential. Judith, is video stuck just on my side? It probably is, Judith. Reboot your system, or close and get back in. We had that earlier, and this does happen. Past history of leprosy, not to my knowledge. So leprosy, as you know, there's two types of it. There's the tuberculoid, and then the one that has the diffuse inflammation, the lepromatous. Lepromatous has more organisms. I've seen leprosy in Africa, and most of the sinonasal ones have been in children, mainly congenital, causing nasal deformities. But there was no history of leprosy here. This sort of morphological picture does not remind me of leprosy, but hey, I did the fight. Just to get that out of the way, I did the fight and the Zeal-Nielsen, as we all call it around the world, but here in the US they call it AFB. I did both of those, and the fight was negative. So fight, as picks up the very thin lepra bacilli. They're much shorter than the mycobacterial tuberculosis bacteria. But these are all good thoughts, guys. In the end, I gave a morphological diagnosis, I gave a differential, and asked them to do the relevant stains of that. And I think I did call the clinician to ask whether he or she had asked the patient about drug use as well. So cocaine is good. Even though I did not see the polarizable, they're very few and far in between. That's been my experience. I've seen about 2 cocaine cases, and you find them, but they're very few and far in between. And remember, the vascular change is there as well. Okay, they can cause ischemic myocardial injury as well. Just FYI. Okay, let's move on then. 2:08. How's the time? 1:40. Oh, we got 15 minutes more. That's good. That's good. You guys are working very hard there. Okay. 2838. 2838. Oh, there we go. 2838. What is 2838? Oh, this is an interesting one. So all you guys out there, you're gonna enjoy this one. I've shown this before. I cannot remember on what platform, but it's one of the cases that came to us from the outside. Patient came here for surgery, and the history was that of a soft tissue mass in the upper chest wall. That's what I was told. So I'm just giving it to you the way it was given to me. The surgeon had us review this case. So it's an outside case, which means the surgeon obtained the slides and sent it through to the department, and we then get to review it and give our surgeon our interpretation. So this was a soft tissue mass, 3.5 centimeters. He was a young male, as I recall. I've got your adult male, but I remember him and it's male, so being between 35 and 40, somewhere thereabouts. So that's young in my book. And this is it. So a scrappy piece of tissue. And even at this power, you can see it's cellular. Just ignore those rings. I obviously showed it before. Why did I ring those areas? Oh, okay. I know why. But anyway, here you can see the spindle cells. I'm just going to show you the components and then we'll talk about it. Here you can see these spindle cells streaming along. Here, vague palisading. Here, cords, nice, beautiful cords. Trabeculae, some people like to use or say. Bit more palisading there. And then streaming along. Note the back. Yeah, I know. I said palisading, Sheena. Schwannoma. Get it down there before we forget. Absolutely. And this background is sclerosing as well. So that's a spindle. Yep, Tiba. Verocay bodies. Look at this kind of pattern here, right? I mean, this strands interlacing, interconnecting strands and trabeculae or cords, if you like. Here it's a little more edematous, more spindle cells. Okay, so enough of those components. And then here, let me do this first. Here you have some fat cells. And you can see these spindle cells streaming in between the fat cells. Okay, invading or infiltrating. But I showed you quite enough spindle cells to show you they're pretty bland. No mitosis, no atypia, no necrosis, no nuclear pleomorphism. And you can see the spindle cells invading the fat here as well. Okay, so you got that pattern. No particular distinctive pattern. And then here, these I deliberately ringed as well, long time ago, to show you these structures here. Look at these. Okay. Now, yeah, Maria, DFSP has to come to mind. Is that honeycombing? In fact, CD34 is positive, Maria. Let me just get that out because you mentioned DFSP, Tiba and Sheena mentioned schwannoma. S100 is negative, SOX10 is negative. But CD34 is positive. So if you thought of DFSP and did the CD34, yes, they are positive. But what about these structures? This seems to be an integral part of this process, right? What do you think of these areas? Okay, if you cannot see it or if your screen's frozen, these look epithelial to my squamoid. Thank you, Mo. They look squamoid. Yes, squamoid with a cystic degeneration, a sort of microcyst, if you will. But these do look squamoid, spindling there as well. They're much more cohesive. And then look at this area here as well. So they're clearly epithelial. And here you have these microcystic spaces with that same epithelial lining. Okay, looking pink and squamoid. So would wonder the organ. Nice question there, Jan. Is it metaplastic or primary structure? Adnexal Rouhani. Okay, so we're thinking outside the box. Remember, all I had was soft tissue, upper chest wall, right of mediastinum. That's all I had. So I didn't quite, get a good sense of where this tumor is. So what I did is I called the surgeon, and I said to him, hey, where exactly is this tumor? Because we didn't have radiology. Remember, patient came from the outside, and the patient had come here for re-excision. In truth, I've forgotten what it was called on the outside. I'll be honest, I completely forgot. But the surgeon here was preparing to re-excise the tumor, and he then told me this tumor was just above the sternoclavicular notch. So it's at the base of the neck, and if you can feel the notch in your neck and the sternoclavicular joint, you can get a sense of where the soft tissue tumor is sitting. Okay, it's not in the bone, but it's just at the base, just at that joint, but it's soft tissue. Okay, now Sheena, you made a marvelous contribution here. You said thymus. What are you thinking? Anybody can jump in here because Sheena is leading the way. She's opening the door. Okay, look at these strands and cords. Again, these look a little more epithelioid, whereas these look spindled. Metaplastic thymoma. Yeah, metaplastic thymoma is good. Synovial. Well, synovial sarcoma is a good thought, Tiba, because you have a biphasic component, except this is CD34 positive, right? Synovial sarcoma is a CD34 negative. It's one of the tumors, one of the ways you distinguish. In the old days, we used to use that to distinguish synovial sarcoma example from, say, Kaposi sarcoma, which is CD34 pos. So, but morphology, yes, that does bring in synovial sarcoma, and this is CD34 positive. So I'm going to go back to Sheena because Sheena suggested thymus, and Jan suggested metaplastic thymoma. Doesn't quite fit with the sort of, if you look at this whole thing here, you've got three components, right? You've got fat, epithelial, and then these spindle cells. They do remind you of thymic, do remind you of metaplastic thymoma, do remind you of thymus, and they CD34 positive as well. Here's another epithelial cyst. These are also P63 positive. So here you go, just, okay, settle. Yeah, there's we'll come back and talk about that. Ruani, hematoma. I like that, hematoma. Teratoma, you just have two components if you really put it together, right? You have endodermal or ectodermal, if you will, with the squamoid looking areas, and then some mesoderm. But hematoma is a very good thought, Ruani. And then along with the thymic, so the CD34, P63, the morphology of these cells, and then the closely intermingled, integral is a better word, three components of the epithelial, the fat, as well as these cords of spindle and epithelioid round cells, made me think of a lesion that was first described by Dr. Rosai. And you're going to go back like 40 years, and there's a tumor, yes, but also CD34 pos, tumor known as ectopic hematomatous thymoma. That's what Dr. Rosai called it. And they still regard it as that. There's been some recent ones, mid-teens, that's around 2015, 2016. Cesar Moran, MD Anderson has a paper, but go Rosai and punch in Rosai, punch in ectopic hematomatous thymoma, and you'll get that original paper that he wasn't the original author, but he put through a series. There was a case report before him, but he did put through a series to highlight these, and again, they of branchial cleft origin. This would go all the way down to type 4, I guess, right at the sternoclavicular notch. I have to ask my expert, Dr. Baloch, on that. He knows all those demarcations. If you haven't done that in a while, just Google the branchial cleft pathways, pharyngeal pouch, branchial cleft pathways, because you see abnormal things along there, all the way from the ear, auricle, the posterior parotid, then this submandibular area, anterior to the sternocleidomastoid muscle, posterior to the sternocleidomastoid muscle, and then down to the sternoclavicular notch, and then of course the thymus itself in the mediastinum. Go through that and see the different morphologies that can happen and the different lesions that can happen. It's very useful because you get these resections in the neck, soft tissue that people would just throw into pathology, and it's worth looking at and enjoying it. Maria Jose is CD. Okay, I don't know what that emoji means. Maria Jose, is it sad, sweating, desperate? I don't know. By phenotypic branchial, well, it's of branchial cleft origin. It is. Yeah, that was one of the things that was proposed by Dr. I think, as I recall. I haven't looked at the paper in a while, guys, so we go look at it. Just to come back to some of the other differentials which have been proposed here, adamantinoma. Remember, that is, unless you're thinking of Ailes adamantinoma like Ewing sarcoma, ALES, adamantinoma proper is tumor I think of as being anterior tibial, surface of the tibia. And you get three types, as you know, the spindle, the ones with the epithelial, and the one osteofibrous dysplasia like. So that I wouldn't, bring that into this differential. Settle is an interesting, so is Castle. Those of you who have not heard of that, Google that, and they're fascinating tumors that have been described decades ago. I'm not going to try and recall the acronym spindle epithelial with thymic-like elements, I think, and the other one is carcinoma with thymic-like elements. But Google that. These are all either described by Dr. Rosai or he popularized them. And they in his book, if you go back to his book, they're well described in his book, both Settle, S-E-T-T-L-E, and Castle, C-A-S-T-L-E, around the thyroid, in the thyroid. That's where they occur. Very rare, but well worth looking at and reviewing. I see the time is almost 1:57. Any questions or comments? Anything I'm not addressed in the chat that I can think of? Yeah. So it's more, and he describes, as Dr. Rosai does, this combination of these three components. The fat is always an issue. Is it part of the tumor, or is it just been invaded by the spindle cells? But the epithelial components is a good giveaway. It's a very nice, and that's why that biphenotypic branchioma, because of branchial cleft. That's a nice way of thinking about it. These small rings here earlier, let me just show you why I ring them. Let me back up a bit. Here we go. So this is a very nice feature for thymic tumors in general. And just around the vessel, you get this edematous area. And within the edema, you get some plasma cells and a few lymphocytes. That that look like a mast cell. That may be a plasma cell. I cannot make sure. But that was a trick I learned many years ago from that famous endocrine pathologist who was the chief at Rhode Island, Brown University. Oh my God, I cannot remember his name. I know Dr. Billow should be very upset with me. I cannot remember. But he taught me that, and he said, you don't get that in many organs. When you see that space around these vessels with edema, it's a nice feature of thymic tumors. In fact, there's a nice picture of it in the old armed forces. If you have the old armed forces, it's there. Tumors of the thymus. It's there. I know that it's there. So it's 1:59, and I want to thank you all for joining me. It's been great fun. Come join us again on the 27th of May, same time. And if you have people who want to log on, send your email to Charlie, and she'll put you on, and you'll get the link. You have to register, and you'll get the link. But otherwise, thank you for joining me. It's been nice sharing these cases with you all. And thank you, Charlie. You still there?
Thank you, Dr. Cooper.
Okay. How many attendants did we have today, Charlie?
We had 38 in total.
Okay. Nice group. Thank you so much again. So we'll pick up on the 27th of May.
Great. Thank you very much, Dr. Cooper.
Bye-bye. Thank you.
Bye-bye.